Good afternoon. I'm Patrick Crotty, and this is a case report on diffuse gastric adenocarcinoma in a patient with diabetic ketoacidosis. Gastric cancer is the fifth most common and third most lethal cancer worldwide. It can be categorized as intestinal, diffuse, or mixed subtypes. The CDH1 mutation encodes for E-cadherin, which facilitates the disease's early invasion through the epithelium and for early metastasis. H. pylori, tobacco are the most common risk factors predisposing patients to gastric carcinoma. Typically, patients will be elderly, they'll be male, generally in the age of 70. If they have hereditary diffuse gastric carcinoma, then they generally present before the age of 40. Patients generally have vague symptoms of abdominal pain, weight loss, lethargy, nausea and vomiting. If there's metastasis to the esophagus, there'll be dysphagia. For our patient, he was a 77-year-old male with type 2 diabetes requiring home insulin. He had peripheral artery disease, heart failure with preserved ejection fraction, hyperlipidemia, and BPH. He presented to an outlying emergency department after nausea, vomiting, and abdominal pain for several weeks. His family state that he appeared altered and he had become less compliant with his home insulin regimen. On physical exam, he was tachycardic. On palpation, there was mild diffuse abdominal tenderness, and his mucous membranes were dry. Notably from his early lab results, he had an anion gap of 30 with a glucose of 738, highly suggestive of diabetic ketoacidosis. But with the complaint of abdominal pain, we had to rule out ischemic and obstructive etiologies. On his CTA, there was no sign of ischemic changes. An additional CT showed hypodense liver lesions and lymphadenopathy. The patient was admitted to the ICU, where he received fluids and insulin to help resolve his diabetic ketoacidosis. He was also given potassium replacement as his levels decreased. While overnight in the ICU, he went into AFib RVR and was given amiodarone, which converted him to normal sinus rhythm. For further evaluation of his hypodense liver lesions, he underwent an MRI, which demonstrated esophageal mass lymphadenopathy near the lesser curvature of the stomach and liver lesions. A general surgeon performed an esophageal biopsy during an EGD, and the specimen was sent off to pathology. As the patient's DKA resolved, he was transferred to a higher level of care to receive oncologic evaluation and potential treatment. For patients with gastric cancer, if it's localized, then surgical resection via gastrectomy is the primary treatment modality. If there is metastasis, then chemotherapy and radiation may be required. For our patient, because of his advanced age and his status, he chose, and the distant metastasis, he chose to receive palliative care and passed away several weeks later. About 40% of patients with diffuse gastric cancer have metastasis, which is part of the reason why it is such a deadly cancer compared to its prevalence. Additionally, what I found kind of unique about this case was some of the overlap between symptomology between how diffuse gastric cancer and DKA can present with nausea, vomiting, and abdominal pain, and the importance of using imaging even when you have a strong suspicion of DKA. Additionally, this patient's hospital course showed the importance of rural hospitals. We were a small facility, but we were able to stabilize a critically ill patient, begin the workup via biopsying and sending off for pathology his esophageal mass, and then after his stabilization, sending him to a higher level of care. Additional unique facts were about how while DK isn't associated with gastric cancer, hyperglycemia is a poor prognostic indicator. Thank you for your time.